Hogan of Maryland and the Maryland Opioid Operational Command Center. My name is Robin Rickard. I am the Deputy Director of the OOCC, the Opioid Operational Command Center, and Chief of Staff. Along with myself is Marianne Gibson. She'll be coming up in a little bit to talk to you as well. I'd like to thank NAMI for having us here today, and we're aware that you guys are, you play an enormous and influential role in the mental health policy in this country and in Maryland for over 4 decades. To say that our entire community is better for NAMI's contributions would be an ultimate understatement. So we thank you, and we thank you for everything that you do. So today I'd like to cover fatality data and trends in Maryland, the history of the terrible crisis, our accomplishments in Maryland, Governor Hogan's policy priorities, our organization, the Opioid Operational Command Center, and the remaining gaps that we see, and our governor's work on mental health. As you well know, we are in the midst of an unprecedented public health crisis, and Maryland has been hit pretty hard. According to the Center for Disease Control, in 2017, Maryland has the 7th highest drug overdose mortality rate in the country, with 36.36 deaths per 100,000 population citizen. This statistic places us well below the national average, as you can see, of 22.6 deaths per 100,000. In 2018, there were 2,143 opioid-related deaths in Maryland, a 5% increase from prior year. And 2018 was the second year that Maryland's fatalities exceeded over 2,000. However, I am pleased to inform you that we are starting to see a little bit of a downward trend in the first half of 2019. In the first 2 quarters of 2019, there were 1,060 opioid-related deaths, 11.1% decline when compared to the first 2 quarters of 2018. Fentanyl continues to be the deadliest substance in Maryland, with 962 fentanyl-related deaths occurring in the first 6 months of 2019. This represents a 7.8% decrease over the same period last year. It was involved in 90.8% of opioid-related deaths during this period. Deaths related to cocaine, the 3rd most prevalent drug involved with overdose deaths, declined as well. Comparing with the first halves of 2018 and 19, the number of cocaine-related deaths decreased more than 16%. The general increase in cocaine-related deaths over the last several years can be attributed to cocaine combined with other opioids, which again have been a contributing factor in about 90% of cocaine-related deaths so far in 2019. The prevalence of cocaine points to one of the most striking and frightening aspects of how the crisis has evolved. Dealers are altering everything in their inventories with fentanyl: cocaine, heroin, counterfeit prescription drugs made with fentanyl, and even in some cases, marijuana. Heroin-related deaths declined by 14.9% when compared to the first 2 quarters of 2018, and we are into the 3rd year of significant decline in heroin-related fatalities, as you can see from the chart. But we do recognize that synthetic opioids like fentanyl are starting to displace heroin as the drug of choice for a lot of users. Prescription opioid-related deaths declined by 3.5% when compared to the first 2 quarters of 2018, also the 3rd year of decline. Pulling all that together, the first half of 2019 was a milestone in Maryland's battle against opioid addiction. For the first time in modern history, every major class of substance used in opioid-related deaths fell for 2 consecutive years and 2 consecutive quarters. All opioid-related fatalities were down 11.1, heroin 14.9, fentanyl-related fatalities were down 7.8. Cocaine went down 16.1, and the number of prescription opioid-related fatalities fell by 3.5%. We believe that the decline that we've seen in recent months are partly the result of better prescribing practices by physicians. The number of opioid prescriptions fell from 4.1 million in 2015 to 3 million in 2018, a decline of nearly 30%. This fact is encouraging because we know now that for the vast majority of people suffering from substance use disorder, upwards of 80%, their journey of addiction started with a legitimate prescription opioid. We should also bear in mind that 3 million opioid prescriptions annually is still a lot of prescriptions when the state has a population of less than 4 million. This prescribing data comes from our Prescription Drug Monitoring Program, or PDMP. We're gradually increasing the functionality of PDMP, and we are hoping to get a more granular data on such things as number of pills, number of morphine equivalents, and number of days per script. In Maryland, no county has been spared by the crisis. Every jurisdiction in our state is experiencing fatalities. The 3 hardest hit jurisdictions in our state, based on sheer numbers alone, are Anne Arundel County, Baltimore City, and Baltimore County, partly just because they are very large jurisdictions. However, on a population-adjusted basis, the picture changes somewhat. Baltimore City still remains the hardest hit jurisdiction, with about 51 fatalities per 100,000 population. But the next 2 hardest hit jurisdictions are Cecil County at 35 per 100,000 population and Allegheny County at 34 per 100,000 population. Cecil and Allegheny couldn't be farther any different than Baltimore City. Cecil County is an Eastern Shore county, flat, rural, and not close to a city center. Allegheny is in the west, closer to Pittsburgh than Baltimore and DC, and it's rural, and obviously it has the mountains area. These differences illustrate that the crisis can affect anyone, anywhere in the state, and the same holds true for any state in the country. The crisis has no boundaries. After reviewing the numbers, it's only natural to ask ourselves, how did this happen? So I'm going to share with you what our executive director, what his personal view is of the history. Heroin and the heroin and opioid epidemic that we face today emerged slowly from over several decades and is the result of 4 major shifts in the illicit market for illicit drugs, particularly heroin, in the practice of medicine, in the pharmaceutical industry, and in illicit chemical synthesis. The first of these major shifts began in the mid to late 80s with a period of tremendous innovation in the heroin distribution supply chain. Rather than focusing primarily on the traditional major urban markets for heroin, Mexican heroin traffickers began to focus on secondary and tertiary U.S. cities in a methodical way for the very first time. They began using innovative delivery strategies such as telephonic ordering and home delivery. Customers no longer had to go into dark alleys to purchase their drugs in bad neighborhoods, and opium production in South and Central America accelerated dramatically, largely displacing Asian opium and bringing down the price of heroin. The second shift came in the 1990s with changes in attitudes on the part of medical profession regarding opioids. Throughout the 1980s, long-standing negative attitudes towards opiates were firmly in place, and as a result of questionable research and other factors, however, that consensus broke down. Physicians became more open to writing prescriptions for opioids and opiates, not only for cancer, but for any manner of pain-related ailments. The consumer movement at that time began to focus on pain control as a key measure of quality care, and physicians were rated on how completely they were able to eliminate pain for their patients. Primary care physicians began writing large volumes of opiate prescriptions for the first time, and pain clinics began to emerge in large numbers. As pain became to be thought of as a vital sign, like temperature and blood pressure, when you go to the doctors, especially with your kids, they have that smiley face and then the sad face. On a rate from 1 to 10, how are you, what is your pain level? All types of practitioners, including physicians, dentists, nurse practitioners, and even veterinarians fell in line by prescribing vast amounts of opioid painkillers. The third shift was the arrival of heavily marketed prescription opioids such as oxycodone, particularly OxyContin in 1995 by Purdue Pharma. No company in the history of American medicine has marketed an opioid as aggressively as did Purdue Pharma with OxyContin. Purdue's marketing literature and detailers claim that OxyContin was a remarkable pain reliever that did not have any risk of dependence, one that could be prescribed without hesitation. Within a few years, millions of Americans, including people in small cities and towns and rural areas across the country, became addicted to oxycodone. And we now know that oxycodone was a gateway to the disease. The new generation of heroin dealers that had established themselves in small-town America recognized this. These dealers were more than willing to assist their customers in converting their substance of choice from oxycodone to heroin, which was cheaper and was found more readily available. And then the fourth and final major shift in the opioid markets was the arrival of illicit fentanyl. Legal fentanyl had been around since the 1960s and is usually used for anesthesia and treating pain related to cancer. Most often it is delivered in a form of skin patches, sprays, or other liquid solutions or powder. As such, legal formulations of fentanyl are rarely misused, although it does happen. Historically, in the years prior to 2013, Maryland experienced only about 30 fatalities per year from fentanyl. But in Maryland, we know that illicit fentanyl arrived in the 47th week of 2013. Dr. David Fowler, the chief medical examiner for the state of Maryland, told our executive director, Steve Hsu, that he remembers the day that it started to come to Maryland, where he started seeing a surge in fentanyl in his toxicology tests. And I remember, I was a prosecutor for many, many years, and I remember I prosecuted drug dealers. And I remember my police officers were charging possession with intent to distribute or distribution of heroin. And I got my first case in 2013, and I had to null process the case and recharge it with fentanyl instead of distribution of heroin because I was like, what is fentanyl? I didn't know what fentanyl was. So back in 2013 is when we started seeing it. Fentanyl accounts for the vast majority, about 90% of all opioid intoxication-related fatalities in Maryland. So now let's turn to Maryland's response. Maryland's response to the emergency began with the creation of the Opioid Task Force under the leadership of Lieutenant Governor Boyd Rutherford in 2015. In 2017, Governor Hogan declared a state of emergency, as you all know, related to the opioid epidemic. At that time, the governor, through executive order, ordered the creation of the Opioid Operational Command Center, or we call ourselves the OOCC. This was an important and unusual action. The OOCC is an extension of the governor's office and is a coordinating agency. As such, the OOCC has the ability to work with any and all state agencies and to try to cut through the red tape. The governor made a major budgetary commitment, including a large commitment of general funds. Many states rely entirely on federal funds. On the local level, opioid intervention teams, or OITs, have done a substantial amount of work, and we have created a comprehensive program inventory that captures the OIT's work, and we'll talk more about that a little bit later. And the OITs, or opioid intervention teams, in each jurisdiction, in all the 24 jurisdictions, these OITs are made up of the health officer, emergency manager, the state police, the local police officers, trying to think of state's attorney, the jails. They get together mostly on a monthly basis and really talk about this opioid crisis in their communities and their jurisdiction. The governor laid out 3 major policy priorities that guide us in our work. Those policy priorities are prevention and education, enforcement and public safety, and treatment and recovery. Prevention and education programs include harm reduction, information campaigns, and school programming. Enforcement and public safety related programs include traditional interdiction efforts, but much more, including diversion, such as drug courts and jail-based treatment. And then treatment and recovery programs include crisis services, peer support specialists, outpatient, and residential treatment programs. The mission of the OOCC is to coordinate the statewide response to the opioid epidemic and to assure that all efforts around the state align with the governor's three major policy priorities. We prepare the state's annual strategic plan, and from an implementation perspective, we coordinate with approximately 20 state agencies and opioid intervention teams, like I said, in the 24 jurisdictions to achieve plan objectives. We disseminate best practices and other information by convening stakeholder conferences, including webinars, pushing information through just many different various channels. We identify gaps in local delivery systems and marshal state resources, and we do have grants as well in the OOCC to fill gaps. Finally, the OOCC is responsible for reviewing and approving all opioid-related spending and legislation statewide. I am very grateful for the work of our local OITs and our opioid intervention team staff here at the OOCC has been very busy coordinating with these local OITs across the state to create an inventory of best practices for opioid and substance use response. We've captured this work in the Opioid Use Disorder Program Inventory. And I'm going to try to bring it up so you guys can see it. It's kind of hard to see. It's kind of hard to see, but when we would go out to all these OIT meetings, we've all been out to, we called it the road trip. One day we're in Western Maryland in Allegheny County, and then we're on the Eastern Shore in another county, and we're meeting all-day meetings with all these OIT agencies to figure out what's going on in the community. You know, and there's 75 different questions, kind of like questions that we ask them. Do you have crisis response? Do you have peer support specialists? Do you have inpatient in your jurisdiction? Sober living, drug courts, access to mental health care that someone doesn't have to drive 2 hours to get to. We're very proud of our inventory list. It's about 75 questions, and we feel like it's a model, so we're hoping to share that with other states. I did it. Oh, no, I didn't. Okay, there we go. It's a miracle. Of course, our work in Maryland is far from over, and we still have some gaps to close. We still need to increase the availability of medication-assisted treatment, or MAT, and other programs in our correctional system. Recent legislation requires that all jurisdictions offer naltrexone, methadone, buprenorphine to prisoners. 5 counties are scheduled to implement by January 2020, and the remaining counties should have it implemented by January of 2023. Many correctional facilities will be faced with reconfiguring limited spaces in to create the space needed to administer the MAT, and funding to support a full, robust program that includes treatment, education, workforce development programs, and housing is limited to those incarcerated in local facilities across the street. And I would tell you, when we go out, again, to all these different jurisdictions, one jurisdiction will already have MAT in their jails and their correctional facilities, and then you go to another jurisdiction the next day and they don't believe in MAT. They don't want to do MAT, and they are going to kind of dig their heels in until it's ordered that they have to do it. Finding transitional housing is also particularly challenging for local jurisdictions attempting to place their clients into the community after incarceration. We need more crisis intervention programs. Mobile crisis intervention has proved to be an invaluable tool in jurisdictions that have been able to implement it, but it requires considerable financial and human capital resources that are not available everywhere. Yet we hope to improve that situation as well. Finally, we are lacking treatment options and dealing with severe staffing shortages in the state of Maryland, especially in the rural areas. More sober and recovering housing is needed across the state, as are residential treatment programs in rural counties. Health departments are challenged in the recruitment and retention of behavioral health professionals. We're finding that a lot. Compensation is lacking, and competition for trained licensed clinicians is very high. On top of this, Maryland's hiring practices make it difficult to hire because there's too much time between the interview and the offer, which leads applicants to entertain other opportunities elsewhere. And I will tell you, when we have visited the counties, what really hits me the hardest is the kids. We'll talk to EMS workers and health care providers, and we've traveled across the state, and just a couple different examples. The kids are really, really impacted by their parents who are suffering from SUD. We're finding that grandparents are now taking care of their grandchildren, where you might have someone who's 75 years old and they think, you know, they're in their retirement years. They now have to deal with little ones because their kids are suffering from SUD. Just to give a couple examples, when we were on the Eastern Shore, we met with, and as part of the OITs, the schools are involved as well. We met with, I want to say, 24 principals, and I mean, the teachers go to school to learn how to teach kids. Well, they now are being trained to deal with the kids that are dealing with mental health issues, because one child came to school, I think she was 10, and told her teacher that she had to Narcan her mom before she actually came to school. This child is supposed to study and learn that day when they are having anxiety because they don't want to be in school. They want to be home because they think that they have to save their mom. You know, it's really sad. There was another child, I think it was in Cecil County, where his grandparents hadn't heard from their child, his dad, in a while, and so they called the police. I think it was like they hadn't heard in several days. So the police show up with EMS, and I think there was some complaints as well from, they lived in an apartment. There was some complaints of a smell. So they knocked on the door, and the officers knew right away that someone had passed away in the home. It was in the middle of summer, and this child had been in the house with their father, who had died. I think it was a Monday, and the medical examiner believed that the father had died on Friday. So no air conditioning, windows closed, and when the officers came in, I mean, they were overcome by the smell, and this poor child was sitting there, and because he hadn't had the parent to help them eat, they went into the pantry and were like ripping open, like trying to survive, ripping open boxes and of cereal or whatever they could just to eat to survive until someone came. So it's pretty emotional when we go out and we hear these things. On the Eastern Shore, when we were talking to the teachers, they said that a lot of the students had anxiety, and this was, I guess, in May. A lot of the students had anxiety because they didn't want summer to come, because their parents, you know, are sleeping all day and stealing or taking whatever they could in the house to sell to get money for their drugs. And at school, at least when they go, they get breakfast, lunch, and dinner. The teachers were using their own money to make backpacks, to stuff food in backpacks for the kids so that they could take it home. And they would have to tell the kids, look, when you take this home, put it in your bedroom so that you can eat. And then on weekends, on Fridays, they were having collections so that on Fridays, because they were going to be home for the weekend, they could pack enough food for the child to have for the weekend. So, I mean, my kids, I have 2 kids. I mean, they count down the days when it's summer, you know. We only have 25 more days. I'm like, really? You know, these poor kids don't even want summer because they're afraid to be alone with their parents. So before I turn it over to Marianne Gibson, I just wanted to tell you why, because I think, do we have time? I just wanted to tell you why I took on this role as deputy and chief of staff. I actually retired from the state's attorney's office in Anne Arundel County. I worked there for 30 years, and I was a prosecutor. I prosecuted drug dealers. And just like any attorney coming out of law school after passing the bar, and I get a job at the state's attorney's office, it was conviction, conviction, conviction. You know, they need to go to jail. It's not a choice. If you're committing crime, it's their choice. So they're going to suffer the consequences. They're going to go to jail. So, I mean, I was all about conviction and the conviction rate. And my boss, about 11 years ago, Frank Weathersby, said, you can still prosecute drug dealers, but you're going to go do drug court. You're going to be in charge of our drug court, our circuit and district drug court. And I was like, oh man, I don't want to do that, because we would make fun of that prosecutor. We called them the hugger prosecutor, and in our drug court, we called it, like our prosecutors had a nickname, it's just Kumbaya court. It's not really prosecution. So, what do you do when your boss tells you to do something? You go ahead and you do it because you want to have a job, right? I got a lot of student loans. So I became involved with drug court, and then I started going to all the conferences. We have the National Association in DC every year, and a conference, it's like a week long. And I just became educated on a little bit on mental health issues. I became educated on SUD, and wow, like my life completely changed. Because before, with conviction in jail, I never looked at my defendant's face. I dealt with a defense attorney, and they were just a case number to me. Once I became educated and dealt with drug court, and what you do in drug court, it's just a completely different way of the criminal justice system. We had, I think, about 100 people in our circuit court, drug court, and I mean, these are people who have been in and out of jail. Sometimes we had one person who had been in and out of jail 56 times. And I remember my officer in that case saying, oh my gosh, why are you even putting this person in drug court? They're just gonna go right back out and get back in jail. Well, jail is actually easier for those individuals than actually trying hard in drug court. A lot of defense attorneys would say, no, I'm not doing drug court, Robin. It's a lot easier for them to just serve their time and get back out, and they're gonna violate, so they're not gonna do drug court. Well, what we would do with drug court is, so we had about 100 people, and we would have meetings beforehand, before we would go out to court. And we had drug court every Monday. So we had about 35 people one week, and then we would have another 35 people the second week. And we would go back in chambers, and it would be myself, the program director, 2 caseworkers, the judge, sometimes 2 judges, peer support specialists, the defense attorney, someone from parole and probation, sometimes a police officer, someone from the health department would be there as well. And we would actually talk about every single person. And we would spend, we didn't have a ton of time if we had 35 people on the docket that day, but we would spend at least 10, 15 minutes, sometimes more, on each person. And we would talk about, like if they were in drug court for a little bit, we would say, okay, how's Mr. Jones doing? Did he go to do all his urinalysis? If he's on MAT, is he testing positive just for, the MAT? Did they go to their treatment? And then when new people would come in, we would talk about their evaluation. And I found that at least 90% of them, and I started educating my fellow prosecutors, look, about 90% of them dealt with a major issue in their life. And one, just for instance, one boy, he was about 24, and when he had been in and out of the juvenile system, and then he had been in and out of the adult system as well. Well, what I found out about him was when he was about 10 years old, He was in the back seat of his car, and his dad was driving. His mom was in the passenger seat, the front seat. And Dad pulls into a parking lot, pulls out a gun, and shoots his mom in the head with the child in the back seat. You wonder why that child, is dealing with a substance use disorder, and nobody had addressed it. They may have addressed it a little bit, but once we got him into drug court, I was his biggest fan. I wanted him to succeed, and I wanted to do anything I could to try to get this boy the help that he needed so that he could have a life. I can't even imagine. Trying to think of, and another, just as another instance, another individual, I think he was close to 30, he had been in and out of the system, and come to find out he was sexually molested by his uncle for many, 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 many years. And I know for a fact that he was, because our office was actually prosecuting him, and he was dealing with that. And now he was using and committing crime. So, boy, did my life change. So now I actually retired from the state's attorney's office, and our executive director knew how passionate I was, because all the judges know how passionate I was about drug court and getting people the help that they need. So our executive director called me up and said, hey, I know you're retired, but I have this great opportunity for you to help not just Anne Arundel County, but the whole state of Maryland. So I am honored to be a part of the OOCC. And Marianne Gibson is going to talk to you a little bit about what the governor and the governor's administration is doing with regards to the mental health issues we have in the state. Thank you.
Good morning, everyone. I'm Marianne Gibson, and I am the Director of Planning and State Partner Coordinator with the OOCC. All right, so I think it's pretty well documented that there's a strong relationship between mental health and substance use. So recognizing that, Governor Hogan signed an executive order in January of 2019 that formed the Commission to Study Mental and Behavioral Health. This commission is chaired by Lieutenant Governor Rutherford, and they've been tasked with studying mental health in Maryland, including access to various services and the link between mental health and substance use disorder. Right now, the commission's really in an information gathering phase, and they're traveling around the state to get feedback from constituents on their concerns around the mental health system and how it relates to substance use. And there's an upcoming meeting this Wednesday, actually, in Hagerstown. If anyone's from Western Maryland and wants to join, they are open to the public. So from these meetings, the commission will formulate their recommendations to advise and assist the governor on how to develop policy to address mental health in Maryland. And based on the areas of concern that have been raised, there are 4 subcommittees that have been formed. One is focused on youth and families. One is on the Crisis Services Committee, the finance and funding streams, and then also the criminal justice system. So these different subcommittees will focus specifically on their areas and make different recommendations on policies and programs on how to address these. So our executive director, Steve Hsu, is the co-chair of the Crisis Services Subcommittee, along with Delegate Robin Lewis. And this subcommittee is charged with evaluating Maryland's crisis response system to identify various gaps and then make recommendations on how we can fill those gaps, but then also looking at how mental health crisis services are treated very different than substance use crisis services. And we know a lot of times that's because of the way that these services are funded. So there may be availability of specific crisis services if you have a primary mental health diagnosis, but it's a lot of times these services don't include people if they're having a substance use crisis, and we know that we need to bridge those gaps. So our initial report will be due to the larger commission at the end of December, which will outline the recommendations of the Crisis Services Subcommittee. And then moving forward in the upcoming years, we will be hoping to execute the recommendations in that plan. So again, the regional larger commissions are open to the public, This one's in Hagerstown. I think there's one on the Eastern Shore in December. And the Crisis Services Subcommittee meets monthly, and those meetings are held in Annapolis, and they are also open to the public, so we welcome you to join in on those discussions. So that's it. Thank you. And do you want to close up for us?
I just want to thank everybody for what you do. Thank you, thank you, thank you, because it's so, so needed. Yes, ma'am.
I just have questions because you're talking about mental health and opioid overdose. What is the quality assurance system behind the substance abuse treatment programs? I found myself with my daughter having issues, having trouble figuring out who to talk to when I had complaints or concerns. And there's the way these programs operate, and my daughter's been in and out of several, is very different from each other, and it's not enough individually focused. So, like for instance, I'm familiar with the DD, Government Disability System, and you make your complaints to the Maryland State Law Center. There's the Office of Healthcare Quality that oversees it. It seems like in the mental health system you don't have that, and I don't even know about substance abuse. You're tying it together, but where do you go? Because you talk to the court.
Yeah, I was just going to say, come back up, Marianne.
But they're the part of the, you have to have something outside the system. Like people with developmental disabilities have coordinators of community services. So if you have a concern, which I know some families do about the mental health placements for their children, there's nobody outside the agency they're with to talk to, and they're scared to say something to the agency they're with because they're afraid there'll be retribution against their son or daughter, or maybe they'll get kicked out of the program, or whatever. So, the DD system has a separate system where you come to the meetings, you have an advocate that you can talk to that has some say in the system. What do you do with mental health and substance abuse?
So it sounds like what you're describing is a third party, almost like an auditor, but I was going to a quality insurance.
The Office of Healthcare Quality does hospitals, they do nursing homes, they do DD facilities. Why don't they do mental health and substance abuse facilities?
So there,
It doesn't make sense to me.
I think that you're bringing up a great need. My understanding is that you can file complaints with the local behavioral health authorities through the health department, and that would not be an independent commission, but they are set to review those complaints, and then the Behavioral Health Administration would be the oversight body of that. I saw Heather raise her hand. I don't know if you had anything.
I used to work with employees. I'm in a jail waiting for that. It's called the Local Addiction Authority, and so each county health department has an LAA. So if you just call behavioral health for your local health department, they are supposed to investigate all complaints or any problems that you have with access to treatment, and that's all done also through the state behavioral health. So like all of that is pulled back to the state. So your first step is the local health department. It's called the LAA, the Local Addiction Authority.
And
There's a person in LAA.
in some counties, the counties have integrated, so they would have a mental health authority and then an LAA, but in some it's the local behavioral health authority. But if you contact the health department, they should be able to direct you.
Okay, so now my second question. Case management. My daughter was in 3 different programs. This PRT program, this methadone treatment program, this residential program, and okay? All run by different people. And there's case managers here and there, and there's nobody like overseeing the whole process, like you have in the DG system. And this is very frustrating. I'm bringing these up because you're doing it.
Yeah, absolutely.
Okay, so I'm giving you my feedback right now as a family member. Okay, my daughter passed away from opioid overdose in June.
I'm so sorry.
Okay, so obviously I'm very passionate about this issue because it shouldn't have happened with all the programs she was in, etc. So you have to address this case management issue. And I'm really concerned about some of these for-profit substance abuse programs and how they're treating people. And I mean, I'm telling you right now, I don't have much confidence that, you know, you have a cops watching in just going to these local authorities. You need an outside third party. I don't understand why the Office of Healthcare Quality is not involved. This is obviously healthcare. And why is this left out? And the case management systems just got to be looked at better. And this is the most important thing, family involvement. You've got to you mentioned that one of the commissions was the family system. I'd like to know more about that.
Sure.
I can get involved with that. But the families need to be involved. They need to know what the options are, what the possibilities are. And, you know, we have this HIPAA law, and if somebody doesn't want their family interfering in their life, they sign it away. The families don't get any information, and they're the ones that are dealing with the consequences. They're the ones that, you know, people are stealing their stuff, taking their money, etc. And you know, they have to put them out on the street, you know, to be homeless because there's nothing else they can do. So you just have to look beyond just it's you know, I'm just saying look at the DB system in terms of case management, advocacy, and oversight, and look at how that might affect the mental health system.
Thank you.
Case management is definitely lacking. They do have case management for like pregnant women in the health department, but you have to be like that special population. If you're one of the fortunate ones who get into the Robin's Circle, you have to see this successful. But yeah, definitely the case management piece, because we have lots of good specialists, but that can help the people to get the resources. But you're right, like someone actually looking at like the treatment and like the other services they're getting, just think there's a lot of that. And the family, I'm trying to the benefits and do this and that, and things like software this program or that program or this program, you know, it's really confusing. And it just has to be, I'm sorry, not to interrupt, but it just has to be better coordinated. And I think a lot of people, we need to educate the family. It should be a requirement at all these substance abuse programs and mental health programs that you have a family support group or family education. Some programs do it. Okay, usually it's the private ones that you have to pay for, not the ones that are supported by Medicaid. But the family should be part of the community, and they're not. Usually they're left out in the cold, and they're the ones who have the most valuable information. Yeah, and I still work with families because I'm still doing training with families every day out over here. But yeah, Maryland Coalition of Families is kind of playing that role, but they're not knowledgeable about the treatment your daughter is receiving. They're not experts.
So with, I think she had her hand up, and then you had your hand up, but I'll just make a comment, and then we'll get to everyone's questions. But just to make a comment about the case management, we definitely recognize that that is a gap. And as Robin outlined in the presentation, the OOCC is tasked with developing the state's interagency coordination plan, so essentially a strategic plan. And in this upcoming year's plan, we have identified that as a priority strategy. And we outlined that we would look at other disease models. And so I will definitely check out the Department of Disability's case management program. But we echo your concerns about that, and we're very sorry for your loss of your daughter, and thank you for sharing. All right, I'm gonna go in order of the questions. I think it was you, and then the lady in the back, and then, so yes.
The one thing that I have found in my private practice is that, yes, we need case management services for everybody, you know, but if you have a lot of money, you can get as much quality care as you want. If you qualify for Medicaid, you get some pretty good services. The families who are in the middle class, in the middle, are not able to get the services that they need because their insurance companies are not covering them. or diapers, or, whatever that looks like as well. And middle class being, I find that they're getting left behind a lot of the time when it comes to services because their insurance company won't pay for it.
Yeah.
I can't tell you how many people in drug court, they canceled their insurance so that they could get it.
Right, and like paying for medication.
Because the benefits were better.
Right, and paying for medications, $500 a pop, for a diabetes medication that someone needs to live.
Right.
Their insurance is covering, part of it, but $500, that's a lot of money.
It is.
So, that's something that obviously systemic issues, but, especially, I work in private practice where people do self-pay, they have enough. I also work in Catholic charities where everything is provided free from Medicaid, as long as the community services are available. The middle class is just getting left behind.
I think that's an important notation, so thank you. And then related to being denied for coverage, there are parity laws in place where if an individual has commercial insurance, they have to be, basically those types of services have to be covered. So if you are hearing of clients being denied services, there is a mechanism in place through the Insurance Administration to file complaints, and they will navigate you through that process. And if you need to be connected with them, I am happy to do so. Yeah. So I think it was the lady in the white jacket, and then we'll go to you.
Question regarding the work prison. So, when our ladies come in, especially from drug court, I'm a psychologist, we're trying to figure that out. How exactly do they get there? Because some of them are on drug court, and then some of them are not. These are a lot of the ones that are in drug court have some more advantages and access to services. So we're really trying to figure out how to facilitate everyone who could, because we're in the same issue.
Unfortunately, drug courts are different in every jurisdiction. Like in my drug court, it was you pled guilty, but we deferred your sentence. And then you got into drug court, there were so many people wraparound services for that person. Like whenever I could try to get anybody in drug court, I would tell parents, have they stolen from you? Because if they stole from you, you can you can charge them tough love, but you can get them into drug court. And then they get so many wraparound services in drug court, and we're monitoring them so much, like probably 50 emails a day. Did so-and-so show up for their drug evaluation? If they didn't, I'm going right to the court saying, Judge, I think they might be using, issue a bench warrant, or then the probation agent or the caseworker will call them and say, you didn't show up. You might want to show up because Ms. Rickard is going to ask the judge to issue a bench warrant. So we were on top of that. But every jurisdiction is different. Some drug courts, it's kind of like you don't plead guilty, but you are sent to go do kind of your own thing, which I don't particularly care for. You have to come back to court in like maybe 2 months and show proof that you did your treatment. So what jurisdiction are you?
Well, I'm having Westwood Plains. We get everyone.
Ah, you're Anne Arundel County. Yeah. So it depends on the crime, whether they go to district drug court or circuit drug court. But if you have someone that you think is appropriate for drug court, if they tell you their attorney's name, their attorney can refer them to drug court, or you can call the prosecutor.
Even though they're already there in the prison at a certain time?
It kind of depends, because sometimes were they already sentenced, or are they waiting sentencing?
Yeah. One I'm thinking about is already sentenced.
Because that could potentially, for Anne Arundel County, I know Judge Wax, before we didn't do it, but now we are doing modifications of sentences where they could, they're serving their sentence, but you think they would be such a good candidate for it that they can get their attorney to ask for a modification of sentence to get them into drug court, and then the judge can bring them in and say, okay, I know you have 6 months left, but I'm going to modify your sentence, and you're going to get into drug court, and we'll suspend your sentence to see how you're doing. So, yeah, absolutely.
All right.
So it's exciting to hear you talk about, County Jail Nurse Committee, County Jail about implementing that. Can you talk a little bit more about what is being done to move along and get to a place where by January 1, 2022, everybody's getting into that need while in jail?
I think we're going to have a conference, correct?
So GOCAP, the Governor's Office for Crime Control and Prevention, is really taking the lead on helping to implement House Bill 116. And I don't know if you're familiar with the legislation, but it's being rolled out in phases. So by January 1, 2020, Howard County, Montgomery County, Prince George's County, and St. Mary's County will have to offer all 3 formulations of the FDA-approved MATs. And so it's being rolled out very slowly. There are a lot of educational opportunities for these detention centers to learn about MAT and how it can treat the population that they're serving. So Robin mentioned a conference. We spoke with SAMHSA, and the Philadelphia prison system is actually implementing MAT exceptionally well, and they are probably the national leader in doing so. And so we're bringing in, or we're not, Department of Public Safety and Corrections is bringing in Dr. Herdman from Philadelphia to educate the wardens on how it's going and some of the considerations. But there's definitely some hesitancy in some of the jurisdictions. Not all, but yeah, a lot of opportunities for education, though. Did that answer your question? I think over here, and then we'll get to you, too.
Yeah, I have a question. I mean, not a question, but a statement. In Baltimore City, what I have found that as I've gone through, there needs to be a lot of education for EMT and the police, where there are repeat, what are they doing? OD cases. Mm-hmm. Because my daughter is a physician assistant, and she lives in Pennsylvania. Last weekend, she came to town. And this so happened there was a lady that she attempted to help, and she had to perform CPR for like forever. And the EMT came and she was shouting out instructions to tell them what to do, and they were moving very slowly. It's like, this is Miss So and So, and she just couldn't understand it. And there have been several instances where I've been involved where they have biases, they make assumptions, and they just don't get it. I mean, and then if these people are in this situation and it's constantly being repeated, something needs to be done. You can't force them into treatment, but something needs to be done.
Well, that is a really unfortunate event that happened in the city. I'm sorry that is what happened. But and I think that really brings up the problem of stigma around substance use disorder, and that's very disheartening to hear. That I think a lot, especially in Baltimore City, where they are really the epicenter of the opioid crisis in Maryland, sometimes EMTs do respond to the same patient multiple times,
and it's like I'd rather be trying to save somebody who had a heart attack than somebody who's about to OD.
Yeah, there's certainly a level of compassion fatigue among the first responders, and we know that they are strained for resources and they're tired and overwhelmed, but we don't want them to lose the humanity in what they're doing. So I'm sorry to hear that, but there's a lot of work to be done around educating EMT and first responders on stigma reduction around substance use disorder, and then the police, yeah.
Yeah, because the police are going to instruct her how to do CPR. Mm-hmm. She's a physician assistant.
Right. Ugh. Yeah, well, that's unsettling, but that is a priority of our office as well, is to recognize first responders and to praise them for the work that they're doing, but also educating them on substance use disorder and helping to reduce stigma in the meantime.
We only have 2 minutes, so go ahead. I think they had their hand up first.
Yeah.
So the question I have is in regards to the jails having MMD. What about the prisons? In the state of Maryland, are those going to be incorporated into that? Because I can tell you the population of prisons are obviously they're addicted and the illness that they say they come out.
Yeah, my My understanding is that the prisons are not participating in this, and that a lot of times that I think the only form of treatment available in the prison system is really detox. So I don't believe that they're part of
And
House Bill
unfortunately,
116.
just coming from the criminal justice field, local jails, they're 18 months and you're back out. The prisons, I mean, it's substantial sentences, so I don't think they want to invest, this is just my opinion, I don't think they want to invest in MAT right away, maybe, but I'm seeing a lot of the prisons have MAT on when you're getting ready to get out, like maybe you have a year left. This is just starting, so we'll see where it goes from there.
The Department of Corrections does have a new program where they're working with different jurisdictional detention centers. So for someone who's coming out of the prison system and they maybe have 18 months left in their prison system, they are being reintegrated into the community via their local detention center. And so I think at that point would be an opportunity for that person to be connected to treatment before they re-enter into the community at large.
I was just gonna say, yeah, she needs to hear from that leads officer that just spoke at our little safe partner briefing.
But one thing that, at least for me, that really stood out in a lot of you said is actually, and that is I don't see why the formula that we don't have trauma-specific services, that is so key to why people keep having recidivism rate, as well as going back to substance use as a person with post-traumatic stress as a result of early childhood issues. Drugs were the best way to escape those problems. So that it's not mentioned in all that's been laid out is kind of disappointing for me. And in New York, the whole Department of Corrections just put in trauma-informed specific services in all their prisons. And why we can't have that for people that come into the system in Maryland, but it's just a statement.
Sure, and that may be brought out potentially with the behavioral health commissioner.
Yeah, so like trauma-informed care and then adverse childhood experience is definitely a foundation of the work that we're doing. And so we have integrated into our strategic plan at the OOCC some work around trauma-informed care and then ACEs. So it's probably not as expansive as it can be, but I think we're moving in that direction, but it's definitely really important.
If anyone else has any questions, we'll stay back if you want to, because I know we didn't have enough time to get to everybody's questions. Thank you so much for everything that you do.